again to our next speaker. Come on up, Pam, along those lines. I'd like to introduce to you guys our next speaker, who is Pam Robbins. She has been a nurse for 39 years, and she started off her world as a diploma nurse and moved on forward from every direction. Her background had to be working at a union hospital, where she represented and worked hard for nurses to actually gain recognition and support what they do. And at one point, she actually had to take on the union. The hospital eventually ended up firing her for the work that she did because of her voice and her advocacy for nurses. She actually went on to sue and to win against this hospital as well. She's the past president of the Illinois Nurses Association, and today she is a current professor of nursing at the Milken College in Decatur, Illinois, and it teaches health policy and economics. So with great pleasure, let's introduce you to Pamela.
Hello. Welcome to the movement. And how many Illinois nurses are in the room? Oh yeah. Okay. So one of the things I think is really important is my dad always said, there's only one person going to hold you back, and that's you. So whatever you want to do, that was back when there was punt, pass, and kick, and girls couldn't do that. I was the one that was always a quarterback. But I didn't get the prize for that because there was no process for that. So I thought I was the cat's meow when I went to my diploma school, and I felt very empowered because my teachers told me that I was a safety net for patients, and I believed them, and I still do today. The problem is the healthcare system has turned into the business of how to make money and how nurses are going to be, you heard Rebecca said, in the room charge. There is no value in nursing because they don't want an articulate, agitated Italian woman to tell them how to do it. So when we talk about empowerment, I was a packing nurse and I learned so much from the anesthesiologist. We were an interprofessional team. When we had a problem, when we couldn't take care of it and we pressed the button, there was like 3 anesthesiologists running through that doorway. I was respected. And I was pretty much a virgin to think that I was the only thing that was going on in my world until we decided that there was going to be a union. And the union was a wonderful thing, but it had me on strike for 61 days in 1993. Every week, my priest, Father O'Malley, would hand me a letter from the Bishop Imish, he was supposed to instruct health and nurses to cease the work stoppage. They couldn't even say the word strike. And I started to understand that nobody defines me except me. And the nurses had found, of course, living in a suburban in Joliet, not too far from Chicago, there's only pretty much one hospital for you to work at. And people were frightened to think about going and working somewhere else. So they started doing the travel nurse, going to work as agency. And while we're on strike, they're like buying cars because they're making so much money. We learned how to collectively work towards an end and a need. And we were the first private hospital in the state of Illinois, I do believe in the country, that had a union. Well, one of the things that it taught was how to do contract language and how to make policy. I was always a big, wonderful policy one. The hospital, looking at your work policy, they work in that all the time. Nurses love to follow rules. We do. The thing is, as the 90s wore on and the do it right with less, do more with less, the right sizing. You know what happens when you do more with less? When you don't have any, you get less. It's like, it doesn't make sense. But I'm still accountable because I have a nurse license. So when they decided, after 15 years or so of being a nurse and having a union, unions get a little too big for them, so they wanted to kill the union. So they thought they were going to fire me. So they fired me. Doesn't cut the head off of the union. There was like 600 nurses back there. We never did get to have a union shop with and everybody had to pay their dues. But at the end of my win, which is we settled amicably, they bought me very many party gifts, and one was don't come back here to ever work again. I was able to negotiate as a part of my settlement that all the nurses at St. Joe's Hospital would have to pay their union dues. So that closed a chapter for me as I moved on to be within the organization of the Illinois Nurse Association. I've been very active in policy, government relations, and learned that there's another path for people to follow as nurses. Sometimes going right into the fire where you're working can burn your tail feathers. But we have another process, and they don't teach that in nursing school. In undergraduate school, they don't teach political advocacy. Why? People can vote when they're 18. We outnumber any other health professional in the United States, say the world. So why don't we do that? So one of the things that I was able to be, I think, very humbled but also empowered to do was to work on the state legislature. So about 10 years ago, with all the other things that we've done in Illinois, during my tenure being on the board, we had no mandatory overtime. And I heard the story of Nurse Mo say that, she was in her 25th hour. Unless there's a disaster, a nurse can't work more than so many hours in the state of Illinois. It has to be a declared disaster, and then they have to have 8 hours to rest. Okay? The thing is, we as nurses, when we make a mistake because we're too tired, which is why the truck drivers can only drive so many hours, why people who fly planes actually have a second engine on the plane, things like that. Why is it that we're somehow sacrificed? So when I think about the stories, because everybody here has a story. The only reason you're here is because you're looking for another path. Because what we're doing right now isn't quite working. And the best way to do that is through collective power. Union, yes. Nursing organization, government relations, yes. Social media, whoa. Yes. So how do we first teach ourselves how to be politically active? And I just want to share with you, the founder of Nursing Excellence, who's stand up right now, Diana, turn around. This is the gal that's going to give everybody in this room a free CE for Nurses Week. They chopped my presentation to about a half hour, so we want to offer to you a free hour of CE, which is a little bit more deeper of my, would be a 1 hour presentation. So you guys can go to www.nursingexcellenceCEservices.com. We've got cards up here so you don't have to worry about writing it down. But I just want to share with you that political power is a way to empower yourself, but also working together with others can empower and change things through laws. How do we articulate the value of nursing? Well, we really don't do a good job of that because a lot of us are afraid if we speak up, we become an object of their displeasure. And so that's why you have to do things in a group. So we have to expand our patient advocacy to include political advocacy, not to be afraid, learn how to negotiate effectively, articulate the value of nursing using research, and Dr. Mead did a great job understanding the importance of research because even though we know what the problem is and we also know what the remedy is, we have to have the numbers to back it up. And I think about all the good that nursing does, and where's the data? Why is it that they don't use the data in our work environments to show that if you have a certain number of nurses, patient outcomes are better? How can we make the business case? When we talked about, Rebecca talked about the nurses that don't sit on boards of nursing. I did a webinar, Nurses to the Boardroom. 6% of the people who sit on a board of nursing, a board in a hospital, 6% nurses, 20% physicians, the rest are business people. Why? Because healthcare is a business industry. We have the largest amount of our gross domestic product at 18% that we pay for healthcare services, but the United States has third world outcomes. Where's that money going? It's not going to nursing staffing budgets. And because we're still in the room charge. My brother-in-law is a plumber. When he shows up at a place to fix a toilet, he gets show up time, he gets time that he worked in the toilet, and he gets paid for the parts. Why is nursing a room charge, one size fits all, is the money that goes to our nursing budget? Does anybody in this room take care of every single patient the same exact way? No! We were taught it's individualized patient care. So we have to be able to figure out the business case, and that's going to take data. And believe me, if we don't talk about this and start talking up that and articulating the value of nursing, somebody else will make the decisions for us, and that's where we're at today. So how can we use the political process? Well, there's a couple of things that we need to do. We need to become informed on healthcare economics. What's the nurse's role in healthcare economics? Do you understand your political process in your state or in your federal level? Do you know the political process where you work in the local area? Do you build on your political activism skills when you communicate with other people? Are you part of a larger group? Realize that you can affect decision making. Nurses need to serve on boards. Start little, like Rebecca said. Get yourself to the school board. Do they got school nurses there? They don't. You better start talking about that. Because the health care of children in schools is wellness and prevention. 1 to 750, I think is the ratio from the American School Nurses Association. Ridiculous. And the other thing is, you got to be able to start identifying and communicating the value of nursing. And when we do that, then we can change the status quo. I teach health policy and economics to CRNA students in Millikan University in Decatur, Illinois. First thing they say, well, I gotta take a health policy course. I'm gonna be an advanced practice nurse, CRNA. I said, you wanna get paid? Nurse Practice Act, full practice authority still hasn't been reached in Illinois. You wanna be a provider and get paid the services that a physician does? We gotta get full practice authority. So listen up. About the 4th week they start getting it. The other thing is they don't know what healthcare is like in other countries. So we started doing a little deep dive into how the healthcare delivery system works in other places. The role of nurses in healthcare economics, there's a wonderful book, resource. This is actually from a teacher who is out east. Well, guys, I'm out east. I grew up 60 miles south of Chicago. It was 42 degrees when I left, okay? So her name is Betty Ramber, and she has a book, talks about the economics of healthcare and helps give a nice little history. Google Betty Ramber. She's also been focused in the nursing economics. Is probably every 2 months it comes out. Lots and lots of articles that talks about the value of nursing, trying to pencil it out, as my husband, the farmer, would say. The processes that are available as a political advocate, you need to know how to work the roles and the roles in your process, and then the power that nurses must embrace to be able to affect change. We're already qualified experts. We all went to school, we all have a license. We have accountability. This accountability is in 3 different things. And you know, if you want to stay safe, you got to know your Nurse Practice Act in your state. You need to know what your specialty standards are, and you need to know your workplace policies. If you can stay within that tridome, you're probably going to be okay. But if you start going outside of that, if you start doing stuff in your room, in your unit, that isn't documented in your policies, because somebody had a bright idea, and somebody gets hurt, guess what they're going to go look at? They're going to look at your policies. So if you're going to change your practice, make sure your policy is aligned with it. And if your policy doesn't align with your practices, then you better make the decision on how you cover yourself. Because when risk management comes around and something happens, they're going to be sniffing for the RN, who's the top of the food chain. Nursing specialty standards, there's a group of people, like research, that aren't beholden to the people who employ them. I'm a recovered nurse, and Aspen standards were incredible. They even had staffing. You have an intubated patient, you're 1-to-1. You have a child, you're 1-to-1. We got to make those specialty standards as the template for how we make any type of national standard for care and staffing. And then, of course, nurses must do more than just follow the laws. We have to write the laws. Dr. B talked about the penalty that hospitals are sanctioned when they have a patient that's Medicare gets returned back to the hospital in 30 days. The first time nurses were ever compensated for care were for transitional nursing services that came hand in hand with those sanctions through the Health and Human Services Department of the United States. They identified the quality that nurses do to keep patients out of the hospital. So best practices are so important. And then trying to understand that this isn't going to stop. Now this is a federal process through Health and Human Services about sanctioning or penalizing when quality outcomes are not the ones that produce the better outcome for the patient. But it's going to start seeping out in other places because private insurance, you can see, I do believe it's either today or tomorrow, they're going to be talking about repealing Obamacare. So we might be just in the right place tomorrow to be able to start Today's Friday. I keep thinking a day ahead. I'm so lost. It's like I'm so excited to be here. It's like my name is Pamela. So when you think about the effect and going and making a relationship with your legislator, before there's some hot issue, you have to develop these relationships because you need to be their health policy expert. And we need to start using research when we start articulating all of these wonderful things. So the Authority of Nursing and Empowerment, there's this wonderful lady, Angela Baron McBride. She says, beware of the dangers waiting to feel empowered before acting on the authority you already have. Nobody needs to give us permission to be nurses. Nobody needs to give us permission. We already know about nursing. We already know how it's supposed to work. They taught us to us in school. But after about 4 years, a brand new nurse says, like Nurse Mom said, I'm like, this isn't what I signed up for. And it's like, so either do you bend, flex, do back bends to be able to stay there? Do you cut down your days? Do you work another shift? Do you go work ambulatory surgery? Where do you go to stay where you want to work, but the environment prevents you from doing that? Well, then we got to change the rules of the environment. That's how we do that. So, nurse economics in a nutshell. Historically, I'm in the room charge. Do I look like a piece of furniture to you? No. Reality is we deliver individualized hours of care to every patient we take care of. I would be in recovery room, and next patient's coming in is the DNC, right? I'm going to be my D. If I would call out, well, I want to do the DNC. My DNC would be in DIC because that's how my luck would always run. So, just because somebody would have a diagnosis, it doesn't mean that that's what it's going to be because patients are individuals. Research. Dr. B talked about research. It is so important, and there's such a body of knowledge. Back when I graduated in 1970, the decision to decide whether they were going to go with medical research or were you going to go to nursing research. And the American Nurse Association said, let's do that nursing thing. And that's where that started to happen. And it has just continued to compile and grow, and people keep asking more questions. So how is it then that there's a remedy to do this? Well, there's a thing called bundling of payment. Instead of doing this fee for service, which is every single time a patient sees somebody, they get charged. We do a bundling. So you had a broken ankle, so you need rehab. So we do a bundle of payments. And so we're going to see the physician is going to be some type of a provider relationship for like maybe 4 times. That's what it, not to like nickel and dime people, because again, all the times that people go to the doctor, they get charged for something, and everybody takes a little teeny tiny piece out. Everybody takes a little tiny slice. And the patient, there's nothing left, and there's nothing left for a nursing budget, because we're an expense. I want to be in the asset side that provides the better quality outcome that decreases the overall health care cost of the patient. So we need to go to value purchasing when we think about doing payments. Okay, so negotiations. I love negotiations. First thing is you sit down and start talking to somebody, and you're like really nice, and you start asking some questions, and they can give you some really good stuff before they think they're negotiating. So you have to know what are they thinking. And then another little tip is you probably agree to more things than you don't with whoever's on the other side. And you have to start thinking about what is important to them. Well, bottom line is important to the other side. We've got research that shows us that we provide the avenue to get better payment and less sanctioning when you have adequate numbers of nurses. But who's articulating that if there's nobody sitting on that hospital board that's talking about it? So when I think about the back and forth about trying to get something out of somebody, and you know, every single one of you have done the negotiation before you even got down here today. Who's getting the coffee? I'll get the coffee. You go park the car. Who's going to pick up the kids today? I'm not making supper. You're getting the pizza. All these things that we do. And then having the doctors think that it's their idea when you want something. It's like I would be in the recovery room and Dr. Tan would come up and I said, Dr. Tan, I have a question for you. Because I'm the nurse. You have the higher level of education, other scope as the anesthesiologist. She'd see me come and she goes, Pam, what do you want? I said, no, I'm going to tell you a story because you need to know what I know to match with what you know. And she goes, I know. What do you want? So the thing is how do you do this? You prepare. You identify what your important issue is before you start into the discussion with this other side. You approach the other party to meet. You be clear and you want to be intent as a listener because they're going to tell you what they want if you listen hard enough. We are always so ready to try and guess what the next, you're thinking, what's the next thing I'm going to say? And you're blocking out the person you're talking to. When they're giving you what it is that they need, and saving money on the hospital side is exactly what they want. So we need to find the path to get there. And they've had all this time to figure out how to do staffing correctly, and they haven't. So we're going to have to fix that too. Separating people from the problem, again, do you think that this spiked up hair, walking and running down through a hallway is something that you want to engage in? Maybe not. So maybe my girlfriend who's 4'8", Nancy Shepherd, who was like 42 kilos, who is like a little tiger that works in the emergency room, is maybe the better spokesperson for today. So I go back and Nancy moves up. Know your team, know your strengths, know your weaknesses. Because sometimes you don't want this telling you your deal today because I just dealt with you yesterday in my recovery room, okay? So you have to be able to squish it down and stay focused because being distracted and rattled is exactly what helps the other side, okay? And then you need to always continue to use those skills and strengthen them as you go along. The thing about the dynamics of power, and I wanted to kind of run in on this just a titch. The social media network that is here today that I didn't have at all, email, which just started to come around. You send an email message and you can send the same message to a number of people. That's what got the Nurse Practice Act in Illinois probably to a point where we had Nurse Practice Act language in our Nurse Practice Act law. Because you could say, you weren't doing the telephone, hello, this is Pamela. I want to tell you we're going to work on this, these are ideas. So you tell Diana. By the time Diana tells Sally, and Sally tells Susie, and Susie tells Miss Frankie here, it's like instead of the